Oh, yeah, sorry, I didn't want to just like move yours. Do you have a yeah. One chair. That's all right. Sorry. No, I was my fault.
Not really the best player. That was my instead of so when 1 o'clock comes. Thank you. What? Yeah, I like that idea. Yeah, that's what I like. Yeah, she was really fun. That's a weird abbreviation. Yes. Perfect. Thank you. Yes.
Okay, so I guess we'll go ahead and get started with the second half of the day. Hope everybody enjoyed lunch. I just wanted to briefly discuss the reason behind today's workshop. I know I talked about it earlier, that Unity House Repairs are partnering on a demonstration project. And this is going to service people who are living with HIV and AIDS and who are also displaced homeless or at risk of homelessness due to goal is to develop the screening tool that I talked about, and we're really looking for your expertise in that, and I have set up 3 different work dates. So we're looking for volunteers today. We would love to have everybody represented, so the medical community, housing community, HIV and AIDS community, as well as DV. So you can sign up for that out at the table in the front where you signed in. The agenda has the wrong dates, unfortunately, so I just wanted to say the cards have the right dates for the work groups. So, yes, we're looking for the same group. The first meeting, we're going to really develop the tool. Second group will be reviewing it and then hopefully finalizing it so that we can kick off and start enrolling clients in the program, which will be a housing program. So we will have housing available. It's going to be transitional housing. And the criteria is that you are HIV positive and either homeless or at risk of homelessness due to a current DV situation. So we are going to be doing 24-month housing, and you will also be receiving case management services through Unity House. And like I said, we're hoping middle of April to start enrolling clients. And we will be doing housing for 15 clients the first year, 15 the second, so 30 in total. So it's really exciting, and we're hoping that you guys are all excited as well and ready to join us. And like I said, really, really interested in getting some feedback for the screening tool.
To say that we're one of the 8
Yes.
groups that was spread,
One of the 8
and
groups.
we meet monthly with the other groups, so any information you give us will be fed into the whole.
Absolutely. So if anyone has any questions about that specifically, anybody during one of these, Dave, Danielle, myself, Jenny, we can talk to you about the program in more detail if you need it. I would be more than happy to come out to your programs and talk to your staff or come to a staff meeting, training, and also do it that way. So just let me know, let them know if you have any questions. Okay, great.
Okay, I feel talking to everyone at this lunch than preaching to the choir or preaching to the converted. Everyone in this room, I think, gets it. But we're going to get pushback. The moment you go outside this room, you're going to get people say, I'm not fully engaged in that, or passive-aggressive behavior. I'm sure you have it the same as I do. And the pushback can come from physicians, nurses, other healthcare workers. And, well, yeah, we should do it, but that person should do it. You know, we've all met that. It's not my role. I'm busy. That person's not as busy. I'm not comfortable doing it. I'm too busy. I've got 15 minutes to ask 35 minutes worth of questions, and I completely understand. You're going to get pushback unless you address it. Well, if I do get the answer, what the hell do I do about it? Which means I don't want to ask because I don't want to have to deal with it. So you may need to make things easy. You're going to have to deal with that re-traumatize. I can guarantee that will pop up somewhere, and someone will try and use that as a cop-out for why you don't ask again. You will meet the, well, I'm not sure in my 15 minutes to ask 30 minutes worth of questions, I need to ask that because they would tell us. Okay? You need to address that. And these are issues I've encountered, I find personally just a little bit irritating. And so, because I'm a believer that actually facts should drive programs, I had a wonderful medical student where, as part of the summer project that led to a very nice paper we published in AIDS Care and STDs, we took 160 of our patients to see what they felt was appropriate about IPV testing. HIV patients. And there is nothing more compelling than individual based opinions to say, well, we actually asked the consumer. That is very powerful data to block the, well, it should be someone else. I'm a man, I can't ask a woman can't ask a man. Well, it should be a social worker. No, it should be the doctor. No, it should be the nurse. So we ask our patients. It's very tough to argue against that. And what we did is we had a female medical student who changed her career. She got really into this, found it extremely interesting. And we sampled our patients as they came in, not just those HIV. We took everyone because we wanted those without as well as those with, because their opinions might differ. And we looked at, actually, although it's only 10% of our, well, it was 12% of our patients, it actually is reflective of the whole lot. And the first question that we asked these patients was, what do you think? Everyone in this room is thinking, yeah, we should be asking, well, do our patients think it should be a routine part of HIV care? Preponderance of absolute yes. Of course, those both with IPV experience and those without both said yes. There were some who didn't provide an answer. Then we asked, were you ever asked about IPV exposure at any time in any of your healthcare contexts? 20%. I think that probably reflects, I don't think we're any worse or better than anywhere else. People will go in, and it's amazing. You see someone who's been in and out of the ER multiple times with trauma, no one's ever asked them because it was a man. It was a gay man, but no one ever asked that his husband was beating him up. So, no patient said that they would think that they would be re-traumatized. And if you do a meta-analysis of, you look at all the controlled trials, asking increases identification and it increases referral. No one has shown that asking causes grief in proper trials. And there is a suspicion that actually by asking, you remove a kind of dark cloud hanging over someone that they've never told anyone, and it can actually be therapeutic. And we've got a little bit of data we're trying to look at to see if we can show that quality of life because of disclosure in a safe environment actually is therapeutic. No one yet has shown it actually decreases abuse, which I think is something I'm trying to show, and I think you could show. Do we actually really diminish the exposure by asking? And certainly if you set up a program, that's a lovely outcome to justify your program. Maybe tough to do, you may need big numbers, but do you actually stop the thing you're trying to address? Probably yes, but let's show it. Some guidelines suggest only women. I think that's clearly wrong. You've got to ask everyone. And some of our most violent IPV experiences not resulting in death actually was in our MSM community. So the patients are telling us, yes, you should ask, with a p-value of 0.001, and no one's ever asked us before you did. The next question comes to what we were discussing there. When do our patients say they should be asked? And half of them said roughly at the beginning of care. The other half said after a few visits, and some said no preference. And this comes back to, I think, what we've heard from several of you. If you feel that you've got that relationship where they'll tell you, that's the right time. If you don't feel, asking it, I wouldn't bother. If you really don't think they've trusted you yet, I just put that on the to do it next visit list. That's not what I think, that's what our patients are telling us. Yep.
So if you look at, it's like 83 to 75. If we work together beginning and no preference, that's 75 versus 83. So it would suggest that following a couple of clinic visits is not so strongly preferred that you should not ask a preferred visit?
Well, I think, yeah, but some people did not say, they didn't answer the tick box first visit. They said after a little while, which tells you that in their mind, they felt they needed to trust you to tell. Some felt comfortable, well, I'm here, I've got HIV, you know, I've got a terrible disease, you know, it's stigmatized, whatever. I wouldn't tell it, I tell everyone everything. Or they might say, well, this is another part of my life, I'll keep over here till I feel comfortable.
Well, and also you told that anecdote about where someone asked and then 4 months
Yep.
later,
Yep.
having thought about
Yep.
it, she
Yep.
disclosed. So I'm just nervous about the recommendation not to ask at the initial visit, because it seems like a missed opportunity to get people's feelings.
Well, but then 53% said following a couple of visits.
Okay. You're the doctor.
I'm not sure if it's right. You could ask and then reintroduce. But I just, you know, I don't want it to become a, well, in my program, I don't want it to tick box. Tick, 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 tick. Ask about IPV, good, that we've asked. Because then it becomes a bit too routine. People don't think about it and trust it.
Thank you.
The next question is, they should ask, yes, we should do it. So we asked our patients, who are you going to talk to? Who do you think should be asking you? And about 20% said the doc, 20% said the nurse, 13% said the social worker, and half said, if it's someone in the program, it really doesn't matter. And that's very reassuring because it means I can ask any of my staff who feel comfortable asking to ask. Well, I think they should all feel comfortable. But we don't have to say, well, I don't do that. That's the case manager who asks, not the doctor. Or the doctor say, I'm the only one with the medical kudos to ask about this. It can be any patients saying, we don't care. If they're in our HIV care program, anyone could ask. We also wondered about whether it would be a man asking or a woman asking, or whether they really didn't care. Most of them didn't really care. There was a slight statistical tendency towards women, but maybe it was because a woman was asking the questionnaire to the patients. Again, it came back to the trust. So they don't really care who asks. They don't really care man, woman. They don't really care discipline. What they then is not immediate, perhaps, but definitely at some time. Then we said, well, what sort of questions should we ask? And here the results are interesting. We gave them 3-4 options. Are you currently experiencing any form of abuse, including, we listed the whole economic gamut rather than are you safe? We said, you know, are you currently experiencing any stress in your relationship? Which some would say is pussyfooting around a problem. Are you stressed today? Or we're a bit more specific, we're really bold with this. Are you experiencing stress due to an abusive situation? So our patients kind of said, let's go for the whole meal deal, and said physical, psychological, sexual, neglect, whatever. I like that because I think it captures the things we were talking about. People think of physical and sexual, but they don't think of financial or neglect or food insecurity. So, you know, the question at the bottom, I'm not sure where you can see it, it's on the handout. You know, we have actually a little spiel, and I mentioned about what sort of questions, how you define it so everyone understands. This is the algorithm that we follow, and I'll go into it in a little bit more detail. Basically, we give a spiel, and then we say, if yes, we go into a semi-structured thing. Was that as an adult? Was it as a child? Is it current? How many times? And if no, we just say no, and then they ask for the next visit. And on the right there, we send them off for a professional consultation. If the in-house social work team don't want to deal with it and can't deal with it, or think it's better dealt with elsewhere. The next question comes back to what one of our group does, is we say, well, how often should we ask? And again, I put this question out because maybe it shows I'm really tentative on this deal. I thought, if you ask and keep really addressing it, people will answer yes because they think, well, you know, maybe I should be abused. You know, maybe I need, you know, why aren't I abused? So I was kind of thinking, oh, maybe we shouldn't ask. We asked once, we give them the opportunity to ask again. But this kind of staggered me because everyone said, yeah, you should ask at follow-up visits. And then we got into, well, should it be we see patients every 4 months, and that's because of our drug reimbursement plan. We asked, well, should it be every 4 months, maybe every 8 months, or once a year, or I don't care. And yeah, you should not just be asking once, you should repeatedly ask. which I think tells an important message. I haven't got the slide there, but we actually broke out how often you should visit. And anyone who'd experienced IPV said every visit. And even someone who hadn't experienced IPV in the last 10 years. And when we explored with them, well, why do you think that? Because once you've been a victim of IPV, either you find people who beat you up, or the people who beat people up find you because you're vulnerable. And that I found was very compelling, that our patients said, you shouldn't pussyfoot on this, you should ask all the damn time, and if we've had IPV, you need to ask every visit, because we're to increase risk, which is true, statistically increased risk of re-establishing ourselves into a violent situation. So our patients saying, yeah, you should ask every visit, doesn't really matter who asks. Then we were a little bit interested in, asking is good, it may give a sense of release, a sense of disclosure, but what happened, and we asked, did you agree to see the social worker? And only a quarter of the people who described IPV on our intake or on our subsequent visits actually wanted. So only 1 in 4 took up a resource that could potentially help them. That may not, I'm not sure that's good or bad. Maybe it's really good because the other 75% have accommodated and adapted and are not struggling. Or it may be terrible that we should be getting 70% going into therapy. I don't know. And then, if you saw the social worker, what happened? Did they refer you on? And we didn't have a high transfer rate, but it's something that we're following. How many people that we identified did we act on in this survey? And the resources that we tended to use were the shelters, the support groups, social work, and psychiatry. Psychiatry was a useful tool to have in our toolbox, and we're lucky we've got a couple of psychiatrists who will see our patients. For someone on our either intake or subsequently discloses IPV, we offer psychiatric services. We think it's complex and we get social work involved as well, because it's not just take some Prozac and you'll get over it. You need to figure out what the root causes and what the subsequent negative effects of IPV are. We also, on someone who discloses, we go into housing insecurity, income insecurity, are they being controlled? We often have to help out with their criminal justice system charges. And sometimes you can actually be really helpful. You get them in stable housing, write a note to their adherent, they moved out of their abusive situation, and our courts are somewhat more compassionate than they might have been otherwise. One thing that we found is, don't expect to solve everything. You ask and then you try and help them. But empathy goes a long way. And even when you hear some awful story and you say, that is terrible, I fully understand, and I'm sorry that life has dealt with such a rotten series of events. That can be incredibly therapeutic, and our patients told us that. And by offering a bit of empathy, it opens them to rediscuss it, because you say, I'm open to listening to you. I hear this bad things happen. You can come back. It kind of implies you can come back and tell us about this. I am incredibly grateful to my in-house social workers, because they take the brunt of these when we stumble into this. That we always have 1 or 2 on duty to pinch hit if we have a patient problem. So, what are the tips that I have? And I think we're actually, in Canada, I think we're the only program that routinely screens. Several clinics in Ontario, in Toronto and Hamilton are actually starting to screen. In British Columbia, in the women's hospital there, they didn't see a need, but then they had an event similar to mine, and they asked me for my protocols. These are the tips I'd have anyone. Build it into your routine care. Sorry, drop-down box, but doesn't mean it has to be done again. Just, it should be done sometime. I like the idea of a trusting relationship, which is why half the people say not at first visit, because they don't trust you, and they may not revisit it. They may, but they may not. Doesn't really matter who does it, so get a team approach. You know, my alcoholic, I did it because I know I don't mind if a doctor asks, but it should be that someone asks when the time seems right. You need a definition, and I think the consensus I'm feeling fits with the literature is that you can't just say is it physical or sexual, because there are other things that are equally as traumatic out there. So go with the literature. What we as is, I think, a standard definition. If someone finds a standard definition, these aren't, you know, tablets brought down from the mountain, the commandments how to do it. This is kind of the theme of what we've established, and as you've heard, I continually adapt to do things better if I can. So you need a good definition of what you're talking about, and something you're already starting on is you need to know what to do when you find a positive. How are you going to deal with it immediately in-house, or what your referral network is. You need, when you found it, you need to continue to watch patients because they're at increased risk. Well, we've now introducing it with following everyone regularly. So that's what we found from our survey. And then I was told it would be nice to have what we're doing. And this is what works for us. So our operating procedure is when the opportunity arises, and sooner rather than later, we ask the question, we provide the definition. We do it when the patient is alone. Now, we have problems with some people who always come in with either a translator or a control freak. And that is tricky. The good thing is I have a few control freak nurses who just, oh, Dr. Gill doesn't allow that, you have to be outside. Go for it. Then I'm not the bad guy. But, you know, you do need to get them alone, and you do need to be able to talk to them. And you have to, clearly that's a little bit more sensitive situation than someone who's by themselves walks in if you have to kick out the relative, or the husband, or the wife, or whatever. Trust is, we feel trust is critical. And then we keep our records actually on an internal EMR. And every time I see a patient who's got positive, it screens, fires back on my list of problems or relevant. And as a physician, it makes me, I must admit, I treat patients slightly differently if I see IPV experience there. I kind of figure out they come from a different background to the 66% who don't. It may just be the way I prepare their care, or I refer out, or talk to them. Positives, a visit to everyone in the team, so the nurse, when she sees them and she takes them into the room, is aware of their back history. And we list it along with other things like hepatitis or mental health issues. It just gives me extra richness on the background for patients I may know well or may not know well. So, we screen. The patient can say no, they can say decline, or we're at clinics on a really busy day, we haven't got time. If they say yes, we get that questionnaire that's on the toolkit with one paper copy on. We try and get a little bit of clarification at that time on what type of IPV is it recent or past. We also ask about whether you've been asked about it before, because this is about and rag on my colleagues for being not asked. Although we're all told in medical school about it. It's very important. We're told, but we never do it. If it's current, we ask about, are you safe? And do you need or want help? The answers that you need or want help, no, yes, or maybe. If it's yes, immediate referral to the social workers or referral outside. The social workers, if they feel appropriate, do more in-depth screening, and that includes a depression score. We do the ACE, the Adult Childhood Experience Questionnaire. That's again on the copy. and they act on it. That could be in-house care, or it could be referral to outside agency, and that's where, you know, urgent housing for the ones who you think, oh, this is too ugly to send them home. We're starting to log the agency, whether they attended, because you refer people and they never show. And I think that's a good thing to track. Asking what actually happens. You need to track them through the system. And you can do that. You can say, you can phone up the housing agency and say, will you please see Susan because we're very worried about her. You need to let us know if she does or doesn't turn up. You need to track it. And then you need to know in a year's time, and remember, HIV brings the patients back to us. Did you actually change anything? And that's compared to every other IPV experience. HIV brings the patient back to the HIV clinic. So we have an ability to measure what is very much more difficult without the context of a disease that keeps on bringing back to medical care. The agencies I listed down there on bottom right would be ADAC, which is our alcohol and addiction, CHSA, which is the sexual assault crowd, CC4MS is the male survivors of childhood sexual abuse, and CPS is our police service. And we track all of those. Now, after that initial screen, we've introduced a question that's less defined, but we think after you've asked the initial definition, it's not unreasonable to go a little bit simpler. And then we've taken out, are you having sex and is it safe? And we're now asking, are you in an abusive situation or relationship? Maybe not the perfect question. If you come up with a perfect question, I'll happily use it and attribute it. No, yes, maybe. The usual thing, if yes, is it new? Is it ongoing or is it past? Tell us more about it. And again, do you need help? And the maybe or unsure crowd, and some people, then you go into a little bit more definition. So we've got the upfront, slightly different from the repeat visit. So I mentioned tools, and we've got a big toolbox. Well, what are the toolbox? Well, we use 4 of them. The screen test I'll mention, the adult, the adverse childhood experience for those 20% who abuse as children. We do the depression, and then we use a toolbox for the helpful agencies. The screening form is the spiel at the top, and then we basically said, we're doing it for everyone. You're not singled out. We're not judging you whether you look as if you might have been abused, or we think you might be abused, or we think you're that kind of person. No, we just say, we screen everyone. No judgment here at all. Protocol. Blame the clinic director. We ask everyone, and if yes, we say, is it current, is it past? And then we get into the types at the bottom, which is physical, sexual, emotional, isolation. And we make notes on it. And we flagged the sections that may need legal reporting to appropriate authorities. And this is backup notes on what are considered to be forms of abuse. Again, that's from the literature, not ours. Then we use the adverse child experience, if someone experiences abuse as a child, because we want a little bit more background on that. And then we do the depression score, which is fairly well accepted in the literature. In the last 4 weeks, have you had these experiences? And they give you a little bit of, you can gauge on whether someone's affected mentally, psychiatrically. You know, poor appetite, sleeping, depressed, hopeless, trouble concentrating. That again is quantified, and you can score with the depression score about how bad their depression is. So those are the toolbox we use. There may be better ones. These are very pragmatic because we're just kind of plowing ahead with what we think is reasonable, pulling other people's tools, but it seems fairly reasonable to do, and we keep tweaking it as necessary. So, what are the big research questions that I'm thinking of? I'm meant to be doing research. But I want to know, can I document actually asking changes anyway? And that is really important. I think everyone in this room thinks, yes, we may help. But if you're sitting over there, or wherever your Capitol building is, well, does actually spending that time on change anything on our budget? And we need to show that we're accomplishing something, not just asking, well, they feel better, or we did a good job because someone thinks it helps. What does it actually do? And that's where it comes back to the question at the very beginning, how is this affecting your life? Because it is, I've never been able to get a stable job, and then I can show in 5 years' time that such patients are now more stably employed. That is a huge win. So we need to figure out effective what we're asking. I would like to figure out which forms of IPV are more harmful. Being sworn at may be equally or more dangerous than physical violence. Who knows? We offer services, but what about the uptake? As I said, only a quarter of my crowd that experienced IPV, either current or past, wanted help. Well, am I good? Am I bad? I don't know. But what's the experience in New York? How many people in HIV, if you ask, actually do anything about it? Do they need to do anything about it? Again, if they do something about it, they go and see a psychologist because they were abused as a child, or they go into housing, in a year's time or 2 years' time, and we can measure it in HIV, did we improve anything? I think we all believe we do, but let's measure it, because otherwise we won't get budget. You've got to show that you're doing something rather than we feel good about it. I mean, I'm from Canada, but we've got financial constraints, same as everyone else. And this is the way I've got to address it to justify all this effort, is do we actually change anything? And if not, why didn't it? Do we need a better tool? And maybe housing and social stabilization is really good. And we might be able to show it in HIV because the disease brings them back to the doctor. It's different to others where you get such high attrition, you don't know what happens to anyone. HIV, they'll keep coming back to their doctor. We need to get better metrics, assess it better than, well, we've got 30% abuse, we need really better definition on that. And we're also thinking, do we actually, with this repeat questioning that our patients tell us, what's the effect of that? Do we actually stop people being abused because they now know there's someone they can inform? Do we actually